greatest risk. Dr. Mack's diverse experience in academic medicine, clinical medicine, population health, and community engagement led her to BHW, where she works to optimize health outcomes for underserved populations. Next, we have Dr. Michael Warren, who is a board-certified pediatrician and associate administrator of the Maternal and Child Health Bureau, MCHB, part of the U.S. Department of Health and Human Services Health Resources and Services Administration. MCHB's mission is to improve the health of America's mothers, children, and families. Its Title V Maternal and Child Health Block Grant Program provides health care and public health services for an estimated 56 million people, including pregnant women, infants, children, including children with special health care needs, and their families in the United States. And our final presenter will be Dr. Catherine Menard, who is a distinguished professor of obstetrics and gynecology's Division of Maternal and Fetal Medicine at the University of North Carolina School of Medicine. In addition to her duties at UNC, she serves as medical director of North Carolina's Pregnancy Medical Home through Community Care of North Carolina, a statewide program that supports Medicaid beneficiaries and their care providers in access to high-quality maternity care. Throughout her career, Dr. Menard has worked to highlight the shared goals of clinical medicine and public health, thus bringing diverse perspectives together, promoting collaboration, and realizing synergy. She also works with the HRSA-sponsored Maternal Health Learning and Innovation Center, which is a national resource center established to accelerate innovative and evidence-informed interventions to improve maternal health and eliminate maternal health inequities. Now, I'd like to turn things over to Dr. Mack.
Thank you so much, Tammy. Good afternoon, everyone, and thank you to our distinguished panelists and participants for taking time out of your busy schedules to join us today, particularly through our technical challenges. I also want to take some time to thank the Workforce Grand Rounds team for planning this event, which is co-hosted by us in the Bureau of Health Workforce as well as the Maternal and Child Health Bureau. I'll keep my remarks brief so we can get it along, but I want to talk a little bit about the purpose of today's webinar. And that's to provide an overview of our HHS efforts to improve maternal health in rural and underserved areas. So today we'll hope that you'll be able to come away with how to strengthen and enhance women's health and maternal health workforce, promising practices to build a high-quality maternal health workforce, and learn more about HHS efforts to improve maternal health. My bureau within HRSA, the Bureau of Health Workforce, aims to strengthen and enhance the workforce, which of course includes the women's health and maternal health workforce, by increasing access to care, supporting a sufficient supply of health professionals, improving the distribution of culturally competent providers, and developing a quality health workforce. The geographic maldistribution of women's health service providers is well recognized, and shortages of OBGYNs are projected to increase in the coming years, especially in rural and underserved areas. So expanding the workforce would be critical to improving women's health and maternal health outcomes. In fiscal year 2020, we addressed these needs by focusing on 4 key areas. First, we began the process of developing criteria for maternity care health professional target areas and published a request for information. Maternity care target areas will be geographic areas within primary care health professional shortage areas, also known as HRSAs, that have a shortage of maternity care health professionals. In addition, we prioritize funds to award scholarships and loans to nurses specializing in women's health with the goal to increase maternity care for women living in rural and underserved areas. We also focused on supporting a mix of providers in an integrated care model to better ensure continuity of care before, during, and after pregnancies by increasing the types of and distribution of healthcare providers. And finally, we are leveraging our health workforce research centers to support research and assist decision makers at the federal, state, and the local levels to better understand health workforce data. I do want to note an open application that we have, and that's for the National Health Service Corps, in which we added certified nurse midwives to the eligible disciplines for the Students to Service Loan Repayment Program in order to expand maternity services in underserved areas. The application for this program is currently open through Thursday, December 3rd, and there will be information at the end for you all. So these are just a few examples of activities and initiatives that we are engaged in to expand the women's health and maternal health workforce. We've included a slide with some helpful resources and links at the end of the presentation. And now I am really happy to be able to introduce and turn it over to my colleague, Dr. Michael Warren, where he will be talking to us not only about the work of the Maternal Child Health Bureau, but as well as how we can accelerate our efforts together. Dr. Warren.
Thank you so much, Dr. Mack. Good afternoon, everyone. It is a pleasure to be able to join you and provide remarks from the Maternal and Child Health Bureau. There we go, slides are up now. I'm going to briefly give you an overview of the work we're doing in this space. And just as Dr. Mack mentioned, our mission of the Maternal and Child Health Bureau is to improve the health and well-being of all of America's mothers, children, and families. To put this work into context, I want to share a little bit about this, and this pyramid doesn't appear to be showing up correctly on my computer. Maybe it's showing up on yours. But at the top of the pyramid, we're really talking about maternal deaths, maternal mortality, and in the United States, that's about 700 pregnancy-related deaths a year. But that really is just the tip of the iceberg. Below that, we have severe maternal morbidity. So these are serious, unanticipated consequences of labor and delivery. These can be life-changing and lifelong in some circumstances, but there are about 25,000 of those cases per year. And then below that, below the tip of the iceberg, if you will, really is what we think about as women's health across the life course. And in maternal and child health, we really try to think across the life course and where there are opportunities to intervene. And certainly, this is the period we'd like to focus on before bad outcomes ever occur. Just to give you an idea, I mentioned severe maternal mortality and morbidity. You will look and see different numbers around severe maternal morbidity calculated in different parts or in different places, depending on whether transfusions are counted or not. The other takeaway from this slide is on the right-hand side of this slide, you see the map, which shows substantial variation in severe maternal morbidity across the country. And so as we think about opportunities to intervene, it's important to know the local, state, and regional context in which we are working. So with that really high-level background, where do we go from here? And in the Maternal and Child Health Bureau, we use a framework called Accelerate Upstream Together to really guide our work. I want to share with you a bit about that framework, and we'll start with Accelerate. It means exactly what it sounds like it means. We have to work faster. And I want to share with you a report that was written by my predecessor in the Bureau. And in the summary to that report, there's a note that says, clearly maternal mortality is in great measure preventable. No available figures show a decrease in the United States in recent years, and certain other countries now exhibit more favorable rates. You may listen to that and say, well, that's not a surprise. We know that to be true. But what I want to do is call your attention to the upper right-hand corner of that memo. It was written in 1916, 104 years ago. And so as we think about the need to accelerate the pace of change, my hope is that our colleagues who come after us in 104 years are not having the same conversations we're having about maternal mortality and morbidity. As was mentioned in the report in 1916 and now, the rates in the United States are higher, substantially higher than other resource-rich countries across the world. We know there are substantial variations in maternal mortality by race and ethnicity. So if you see in particular for Black and American Indian, Alaskan Native women, those rates are substantially higher for white women, Hispanic women, and Asian and Pacific Islanders. Those disparities persist even when you look across various educational attainment levels. And so, for example, if you look at the far right of this slide, for women who have a college degree or higher, the rates for African American women are about 5 times those of white women when you look. And in fact, the rates for both Black and American Indian, Alaska Native women generally are higher than those for white women across a variety of educational stratifiers. So what are we doing about this? How do we accelerate the pace of change? Well, one of the things that we're doing is supporting states to do innovative work that is responsive to the needs of the women within their states. And so we fund at the University of North Carolina at Chapel Hill the Maternal Health Learning and Innovation Center, where we're looking at state-led evidence-based interventions that are filling gaps in various aspects of maternity care service delivery looking both at morbidity and mortality reduction efforts. We also sponsor AIM, the Alliance for Innovation on Maternal Health. These are quality and safety bundles implemented primarily in birthing facilities and hospitals to date. Thus far, about 38 states are enrolled in AIM, representing about 1,500 hospitals that are participating in bundle implementation at some level. Some of those hospitals are very new to this journey and are just starting the process of identifying what bundle is appropriate for them and data collection. Some are more experienced and have been doing this for a while and may be on their second or third bundle and are already submitting data from a quality improvement standpoint. So I mentioned Accelerate, Upstream together. We talked about Accelerate. I want to talk a little bit about Upstream. And we see this photo of a river. So I want you to imagine that you are walking along this river. It's a beautiful day, and your walk is interrupted by sounds of screaming and splashing, and you look, and there's someone who's struggling out in the middle of the river. And so you jump in, and you swim out to the middle of the river, and you grab that person, and you bring them to the shore. And as you're helping them up onto the bank, you hear more splashing and more yelling, and you turn and look, and there's someone else who's struggling in the river. And so you swim out to grab that person. And as you're bringing them to the shore and helping them, you hear more splashing and yelling, and you look, and lo and behold, there's someone else who's struggling in the river. Well, about that time, you see someone else who's walking by on the bank, and so you call out to them and ask them to help you. But they just keep walking by, and so you call out again, hey, why won't you stop and help me? And that person says, I'm going to go upstream and see why these people are falling in the river in the first place. And I think for a lot of us who work in public health and healthcare, we feel like we spend a lot of our days pulling people out of the river, when really the ideal opportunity for intervention is to look upstream and prevent bad outcomes from ever happening in the first place. So in health, we often talk about prevention, and really what we need to strive for is primary prevention, preventing disease before it ever happens. And when we think about specifically applying that to maternal mortality and morbidity, often our focus goes to the period of prenatal care and labor and delivery, and that's absolutely important. We have to be attentive to those time periods. But life course theory tells us that really it's events across the life course that shape our overall health trajectory. And so if we're thinking about maternal mortality and morbidity, we have to think about the health of women across the lifespan, and that includes among young girls. And so when we look at national data about how girls and women in the United States are doing, we've got a lot of opportunity for improvement, whether that's talking about healthy weight status, or reducing adverse childhood experiences, or thinking about receiving preventive care, reducing health risk behaviors like smoking. There are lots of opportunities to engage across the life course if we're truly going to optimize that health trajectory. I'm a pediatrician by training. I remember when I first started hearing about maternal mortality and morbidity, my first thought was that's a problem for my OB colleagues, when in fact it really is a problem for pediatricians as well, because we're taking care of young girls, adolescent females, who one day may decide to become mothers, and really the optimal time to get them healthy is earlier in life. The other thing that's important to think about when we think about upstream is that healthcare alone is not the solution. I trained as a clinician, and so clinical practice is what I know. So that's a bit of a hard pill to swallow, but the reality is a number of studies have shown that health care accounts only for about 10 to 20% of our overall health and well-being. A variety of other factors, social circumstances, behaviors, environmental exposures, policy, all of those things play an important role and collectively actually play a larger role than health care alone. Health care is absolutely necessary, but it is not sufficient in and of itself. So how are we addressing this upstream work? Well, I mentioned earlier a focus on primary prevention, and so we fund two initiatives that relate to this. In the child and adolescent space, we fund what's called Bright Futures, which is a blueprint for well child care. It gives an outline for what are the different elements of different pediatric well child visits, what are the components of that to support providers. And the counterpart to that for women is the Women's Preventive Services Initiative, or WPSI, which similarly provides a blueprint for well woman care across the life course. This gives us an opportunity to engage with providers and help them think about how they can move upstream and think about opportunities to focus on primary prevention. Similarly, I mentioned that you can't focus on clinical interventions alone, and I talked earlier about AIM, which previously has focused solely on hospital and birthing facility interventions. Over the last couple of years, we've launched something called our AIM Community Care Initiative, And this was done in response to data from our colleagues at CDC that showed if you look at all the pregnancy-related deaths, about a third happen in that time of labor and delivery and immediately 1 week postpartum, but 2/3 of those deaths happen outside of that period. So about a third happen during pregnancy, about a third happen anywhere from 1 week to 1 year following delivery. And so if we're really going to focus on addressing maternal mortality and morbidity, we can't just focus on labor and delivery in that immediate postpartum period alone. We have to look on either side of that. And this gets back to what I was talking to earlier about working across the life course. So we launched the AIM Community Care Initiative. Right now we're funding 5 pilot sites across the country that are going to give us information about how we can move into community-based settings with models that are similar to these clinical quality and safety bundles that are in hospitals and birthing facilities, but that are more appropriate for community settings outside of that labor and delivery period. The other thing that we think about when we think about Upstream are other aspects of what contributes to our health. And we know that mental and behavioral health services are absolutely important. So we're pleased to support a number of states in screening and treatment for maternal depression and related behavioral disorders. Through this program, we're working with states to think about how they work with providers to improve the capacity to be able to work along the spectrum of care, so screening, assessing, treating, and referring women who are pregnant or postpartum to appropriate services for depression and related behavioral disorders. So that's Accelerate Upstream. I want to finish out by talking about Together. When we think about the work of improving maternal mortality and morbidity, no one entity, no one organization really owns this problem alone. It takes all of us working together at the community level, health systems, patients and their families, providers, and health facilities. At the Federal Maternal and Child Health Bureau, we're very focused on national level improvement. And so if you think about these processes as leading up to this national improvement as gears in a machine, we're really trying to move that big wheel of national improvement. But a first and necessary step is to generate change at the local level. And so what we try to do is to get that community wheel turning and make that work. When we do that, it makes that state and regional wheel turn. And then ultimately, once that happens, we can move this wheel of national improvement. The important thing to note there is that national level change doesn't happen unless change happens at the local, state, and regional levels. And so the work that you all do every day in the communities and the states where you live is really vital to our success as a country. One of the ways that we support that in the Maternal and Child Health Bureau is through our Title V Maternal and Child Health Block Grant. This has been around for a long time. It's a very flexible source of funding for states. And we found that in the past few years, many states and jurisdictions are actually using this to support work aimed at reducing maternal mortality and morbidity. And they might do that in a variety of ways. They might try to promote health and wellness before, during, and after pregnancy. They may use these funds to support maternal mortality reviews or surveillance activities, or to support work that they're doing in perinatal quality collaboratives. I also want to give a shout out to our colleagues at CDC who have launched the Hear Her campaign. This is an amazing campaign that really highlights the voices of women as we're thinking about reducing maternal mortality and morbidity. When we think about the together part of Accelerate Upstream Together, one of the important things to remember is we need to keep women and their families at the center of this work. This is not about the federal government saying what should happen or state governments saying what should happen. This really should be driven by the needs and the hopes and the dreams and the wishes of women and their families. And so the Hear Her campaign really encourages us all to stop and to listen to women and to incorporate that voice and their wishes into optimizing their care. So with that, I'm going to stop. I want to thank you for your time today. Thanks to our colleagues in the Bureau of Health Workforce for convening these grand rounds. And I'm particularly excited now to be able to turn the podium over to our friend and colleague, Dr. Kate Menard at the University of North Carolina, Chapel Hill.
Okay, thank you. I want to start by thanking Dr. Mack and Dr. Warren and the Bureau Planning team for the invitation to speak with you today. Each time I'm given the opportunity to speak with a predominantly public health audience, I'm thrilled to learn from you, be challenged by you, and I love to find opportunities to harmonize efforts to accelerate progress toward goals shared by the clinicians, educators, and public health. I also want to tell you a little bit about myself so you can understand my perspective and perhaps potential biases that I bring to the conversation. I grew up in a small town in northern New Jersey, fortunate to have access to high-quality public education. I was exported to North Carolina for college, trained in OBGYN in Philadelphia, but then back to UNC for fellowship and public health school. My entire career has been in academic medicine with clinical practice in quaternary care centers in the Carolinas. While in South Carolina, I had the privilege of working with the public health to strengthen their perinatal systems of care when it was being threatened by financial pressures. And then in moving to North Carolina, I had new opportunities to collaborate with numerous talented and dedicated public health colleagues in the design and implementation of what I think is the country's, probably the only country's statewide population health program for Medicaid maternity care, the CCNC Pregnancy Medical Home Program. My day job is UNC. My main job is UNC. I train OBGYN physicians and maternal fetal medicine fellows. I collaborate in clinical practice with nurse midwives in a state where they still call that physician supervision, quote. My hospital has a robust program where volunteer doulas are available to everyone for continuous labor support, but doula care during pregnancy and postpartum is mostly available only to those who can afford to pay for it. I'm a mother of 3 amazing daughters, young adults, and I'm quick to admit that those experiences taught me more about what women want and need for pregnancy care than any of my 27 years of schooling and training. The point being, listen to women. Finally, my disclosure. I'm not an expert in workforce development. You guys are the experts. What I can bring to you is many years of experience working to improve maternal and infant health from kind of the bird's eye national level and the state and systems level to the care of individual women, most of whom come to me because resources for complex care aren't available in their community. I'll begin by defining the maternal health workforce very broadly. I'm not sure how all of you think about it, but it's important for us to think about it quite broadly. But in listening to Dr. Mch's response, I think you are thinking of it in a similar way that I do. But our first minds go to physicians and midwives and nurses and training those. But the workforce really entails health educators, lactation support specialists, nutritionists, doulas, community health workers, sonographers, behavioral health experts. It's so broad, the circle of village that cares for our maternity population. And if we hope to provide equitable, high-quality, affordable maternal care, we must set our goals on the development of a maternity care team that includes interdisciplinary teaching and training, promoting patient-centered and culturally appropriate care. There's an opening letter in a report that the March of Dimes distributed called Nowhere to Go, Maternity Care Deserts in the United States. Stacey Stewart said, "We imagine a nation where every mom and every baby is healthy, regardless of wealth, race, or geography. Providing women with access to quality health care during the perinatal period is a critical part of that equation." So, as you well know, HRSA programs are improve health care for people who are geographically isolated or perhaps economically or medically vulnerable. While there's a necessary focus on primary care, there's an urgent need, as has been described, to ensure that maternity care is within that scope. So there's a need to increase diversity of maternity care workforce and to offer high-quality, culturally competent care with underserved communities. So I just think it starts with recruitment. It starts with creating a pipeline of committed individuals, training those individuals, supporting the training of the talented individuals and candidates from disadvantaged or underrepresented backgrounds, leading to increasing the distribution of healthcare professionals in the areas of needs, and then retaining them. And so I'll speak to some efforts I think that can support all of that. And underneath the support is, there's facilities that need to support that, but also the financial backing that's required. I'm going to spend a few minutes reviewing geographic needs. This is familiar to you, but as described in the March of Dimes report that was initially published in 2018 and then revised in 2020, bottom line is that 10% of births nationwide occur in counties that they described with limited access to maternity care. Maternity care deserts are defined as counties in which access to maternity care services is limited or absent, either through lack of services or barriers to women's ability to access those services. In this report, March of Dimes defines maternity desert as any county without a hospital or a birth center offering obstetric care and without any obstetric providers. And you can see that everything in red on this map meets that criteria. The low access centers that are where there's only one hospital or a birth center and few obstetric providers, fewer than 60 per 10,000 births, or a high proportion of women without health insurance, which they define as less than 10% of the population. And then the moderate and then the full access to maternity care is defined as availability of hospitals or birth centers, more than 2 in a county, providing obstetric care, and the availability of providers offering obstetric care with greater than 60 per 10,000 births. So this is the initial map. And then what that translates to in terms of people is right here. So 3,139 counties, 54.7% don't have that full access of maternity care defined. 64 million women, 7 million without full access, and 3.5% living in maternity deserts. And then close to 4 million births with about 12% that don't have that full access to maternity care. There are components of it, as I spoke. Access to hospitals or birth centers offering obstetric care by county is illustrated in this map. This is updated in 2020. The darkest spots are hospitals with no, the darkest blue are the hospital or the counties with no hospitals and no birth centers. Looking at it a little different way, many counties, small counties, you can just cross the border and get to a hospital. That's my neighborhood, just to get to Chapel Hills Hospital, just in another county that's more rural. But the travel distance illustrates it in a different way, and certainly these maps kind of illustrate the challenges that we have in our frontier states, and less so, of course, on the East Coast. This was a study that that highlighted the concern that we're dealing with respect to hospital obstetric services closures in rural counties. This particular study was published in 2017 and described some trends in this 10-year period with closures. And you can see the dark filled-in spots. The dark spots on this county were counties who lost the obstetric service in that in their counties. There's 179, I think, in that 10-year period. This is updated now through 2018 and shows the trends in closures. This lower line is the non-core the counties that these counties have towns or have no town that's at least 10,000, and then the micropolitan counties are those that have a small town, 10 to 50,000 people in their county. And you can see the distinct decreasing trend that continues through 2018 with closure of these rural obstetric services. Reasons that are for closure that are cited in this publication, and all these resources are available for you to review, are difficulties in staffing, recruitment of staff, retention of staff, scheduling obstetric providers and nurses, anesthesia coverage, also important to a good quality obstetric unit. Low Medicaid reimbursement is an issue in most states. And the low volume to maintain an obstetric unit where you have trained nurses and trained staff available to care for women with low volume is very challenging. And many of these counties are counties where there's a lower median family income, and the resources to maintain that service just aren't there. So with closure of hospital services also sends obstetricians and obstetric care providers scattered with nowhere to work. This illustrates from the same report illustrates the distribution of obstetric providers. This is obstetrician, gynecologists, and nurse midwives, certified nurse midwives. Included in the report, certified midwives and certified nurse midwives. And you can see that the darker areas, the dark blue, have no obstetric providers in those counties. Insurance plays into it. Financial support for all of this is important. So the third component that they describe in the March of Dimes report has to do with insurance coverage. The illustration on the left shows women without health insurance in 2017. The dark, of course, being the higher percentages of lack of insurance. And it really does mirror what's on the right, which is your illustration of the Medicaid expansion states, where Texas and the Southeast are most affected by women without health insurance. It speaks to the need, the life course perspective. If women aren't covered by Medicaid when they're not pregnant, it's certainly contributing to the difficulties in really taking care of women from that perspective. Medicaid is the nation's single largest payer for maternity care. In 2017, Medicaid paid for 43% of the births in the U.S. Here in North Carolina, it's about 50%. And estimated, in rural areas is 50 to 60% across the country. And many women that's with including Medicaid for pregnant women, many women with pregnancy care coverage alone will lose their Medicaid coverage 60 days postpartum. So that's the lay of the land. Now I just kind of want to talk a little bit about some promising practices to support the maternity care workforce. So some broad categories. Fostering greater collaboration is kind of the theme that really resonates with me. Collaboration across maternity care providers, integrating midwives and family medicine physicians more completely into care is a very important part of the solution. Team approach with really astute attention to social determinants of health is another very important component. We have with a team that can really tackle the various aspects of care. It does not all need to be on the shoulders of an obstetrician. That's just not a good use of everyone's time. We have expert team members who can deal with many of these issues so far better as long as we engage. And then developing and strengthening perinatal systems of care has so much potential. Through risk assessment, ensuring clear lines for consultation, referral, and transport systems can help to support providers that are practicing in remote areas or dealing with a high-risk population, supporting them in the continued care. Telemedicine, I'm going to spend a little bit of time talking about that. And then, of course, policies that will financially support hospitals and care providers in rural areas can be a change. So let's talk about for a minute the scope of practice for maternity health care providers. You know the tradition of obstetrician gynecologists and what they do. They do life course care in reproductive health. They do, and they're trained and they're available in 50 states. Maternal fetal medicine, that's what I do, is specializes in the care of the complex medical, obstetric, or fetal complications. We do an extra 3 years of training. Family medicine physicians, of course, offer comprehensive medical care for adults and children, including reproductive health, and some do a fellowship for obstetric surgical training, 3 years for residency and then another year for an OB fellowship. Certified nurse midwives, I'd like people to make sure they are aware of the types of midwives. And certified nurse midwives are RNs with a master's degree. Certified midwives are usually bachelors and then go to a master's. These two types of midwives have the same board of certification, the same testing to become licensed to practice. Certified professional midwives do pregnancy, birth, and postpartum care. These providers can come with a high school diploma, and they train as apprentices and in an apprentice-type program, and are practicing in 33 of our states. Doulas, non-clinical support and education before, during, and after pregnancy is what they do, and have various ways of paths to education and various paths. And not all are certified. but certainly an area that deserves more attention. And then, of course, our community health workers and their training and incorporation and coordination and incorporation into the care team varies by state. All that to say is, if we start with just our traditional OB practitioners practicing in academic medicine or practicing in private practice, this is my own state of North Carolina and the distribution of maternity care providers. If you just look at it with obstetricians and community practice, that's the distribution of providers. But add federally qualified health centers, and suddenly many of those rural counties have care providers. Now add local health departments and family medicine providers, and then pretty much all of the counties have with few exceptions, have maternity care providers. That doesn't necessarily mean they're all delivering babies, but they at least get prenatal care close to home. This is a map of the practices that are enrolled in the Pregnancy Medical Home Program in North Carolina. Family medicine physicians, this is now from a national survey that was done by their academy. Unfortunately, a lot of family physicians, the trend is to do fewer births. This illustrates the number of family physicians that responded in this survey that they were doing high volume obstetrics, which is greater than 50 deliveries per year. And you can see that rate is dropping precipitously. It started only 2%, and by 2016 only about 1%. And the low volume, where it's 1 to 25, is dropping precipitously as well. In reading about this, the family physician leadership cited a number of different conditions that are contributing to that, and things that then can enable family physicians to include in that to remain in practice in that way. First is adequate training during residency. The trainees need to come out feeling competent and feeling safe in providing obstetric care. It seems that the perfect blend is to train in part in high volume settings, but the limitation of that is then they never really experience what it's like to work in a low volume setting in a rural hospital, and are they really ready to do that? At UNC, a program that our family medicine department has worked on is to train a group of residents that are committed to providing rural care and providing them a robust experience of actually maternity care in the rural setting. We've opened a maternity unit about an hour south of our main campus in a rural area that's family medicine run. Family medicine fellowship trained folks that can do cesarean sections, obstetrician support if necessary, and they're just an hour away. But having our family medicine residents get that experience of what it's like to work as a family medicine physician in a rural area. We're just starting. It just happened that they just opened that this year, and we're really looking eager to see if we can attract these residents to stay in practice in obstetrics in rural areas. Interprofessional education is so important to have our team members, our physicians, midwives, doulas, for them to grow up together so that they know each other, that they learn from each other, and they come to respect each other. It can be an important part of developing this workforce. Ongoing support for hospital privileges and credentialing for family physicians, that can be a barrier in some places. And regionalization, which I'll speak more to, for perinatal support, seamless lines for referral and transport is important. Continuing education. Family medicine has some nice programs for emergency skill training to keep those infrequent skills sharp, infrequently pulled on skills, thankfully, but keep them sharp. And then support for resiliency. Isn't this true for everyone, to prevent burnout, and then, of course, tort reform, because liability in certain parts of the country for people who do low volume obstetrics can be just unaffordable. So similar to this theme of collaboration and across the thing, I was privileged to be part of this group that came together at the National Academy of Science to look at birth settings in America. The work group worked for about a year, kind of studying all of what's out there it was convened by, funded by the NICHD and convened by the National Academy of Science. And kind of the big themes were fostering greater collaboration across maternity care providers, increasing diversity of the maternity care workforce, and promoting interprofessional education, which I spoke. Professional organizations and educational institutions can facilitate all of this. Collaborative undergraduate and graduate training and continuing education across all types of providers. I want to speak for a bit about midwifery care. Certified midwives deliver about 10% of the births in the U.S. right now. They attend 10% overall, but they attend about 30% of the births in rural hospitals. And there are still barriers in place to developing our midwifery workforce. Some of it has to do with licensure. The diagram here on the left illustrates the states that offer independent practice as their oversight modus, and those in green require collaborative practices, and those in blue still have this supervision clause for the midwives. And this is a big barrier. If a physician in North Carolina, or rather a midwife in North Carolina, needs to have a physician sign on in order for her to have a license to practice, and that her supervising physician moves away or retires or whatever, they're left without the ability to really practice obstetrics in that remote area. So lots of work going on here, and it is contentious in some areas as to how to resolve this. But on the right, you can see that there's this nice study was done and published in 2018 that looked at sort of a combination of things that described how midwifery was integrated into care, that included indicators of whether they were regulated, as I mentioned, whether there were any restrictions by law of how they requiring consultation or referral, evidence of quality assurance, prescription writing authority, and there's just really a wide range across the country of requirements for midwifery. If this were more uniform across the country, I think we would be in a much easier place in order to really kind of integrate midwifery care and collaborative care with physicians. If physicians train one place, move to a different state, the rule of difference, it just really adds to the confusion. So one of the recommendations from the Birth Settings in America document was to work toward consistent licensure and consistent scope of practice for midwives across the country. I just lost the visuals, y'all, somehow. Oh, there we go. Thank you. Sorry. So team-based care, a little bit more about team-based care. I want to speak about professional doulas for a moment. And what doulas do, professional doulas are more accessible, need to be more accessible to people with diverse socioeconomic and cultural backgrounds. Community-based doulas provide programs that offer culturally appropriate support to women at risk in underserved communities. Continuous labor support that they can offer has been clearly demonstrated to improve outcomes in the labor and delivery unit. But importantly, prenatal and postnatal home visits they can provide childbirth education, breastfeeding education. They'll often do referrals when needed, and can support the parenting process. The availability of training for doulas is sparse in some areas, and there's a tremendous opportunity to support women to grow that particular piece of our workforce. The team-based model of the maternity home, of course, is something that's near and dear to my heart. In North Carolina, there are 6 core components to the pregnancy medical home model. It is a statewide provider network with providers in, as I showed you previously, in virtually all of the counties of North Carolina. It includes 95% of the care providers that actually do obstetrics in North Carolina. So it is a fairly robust program. The components of it includes standard risk screening that for all the Medicaid recipients. We're successful at getting about 80% of the women screened, and the screen includes important social determinants of health. It includes case management that's based in the community. They're health department care managers who then use the information from the risk screen to determine who will benefit most from care management. We took many years of data from the risk screen that we had in place with outcomes linked to birth certificates, so we could determine outcomes, and we were able to determine which of those points on the risk screen are most amenable to care management, and those cases are prioritized. We also have strong clinical leadership at the local level. There's peer engagement. We believe this is a big part of what keeps our provider workforce doing Medicaid. They have a voice. They have that clinical leadership locally, so they have a path to problem solve if there's difficulties in providing the care and that they want to get to their patients. We have care pathways and a really robust informatics program where there's Medicaid claims are linked to vital records, linked to our care management database and the risk referrals that generates a nice array of feedback for individual practices on their performance on various quality metrics. And that team-based approach with the providers and the care managers working together, these care managers are often embedded right in the offices, gives us a nice ability to address some of the social determinants of health. Regionalization is another promising practice. What regionalization entails, many are most familiar with the neonatal levels of care, in levels of NICU care that are available for the smallest babies. But more recently, that first in 2015 and then revised in 2019, is levels of maternal care. These are coordinated and integrated systems of care within a geographic region, stratifying birth certificates into birth facilities into 4 levels based on specialized healthcare providers and technical resources available for care of the complex medical conditions. By doing this, you can kind of see what the geographic distribution is for your maternal facilities, and around that, then you can fill in the gaps. The idea of this is to build a culture of collaboration for seamless consultation and referrals. The tertiary care centers and the quaternary care centers, by design, would support education, quality improvement, and referral practices for their referring facilities and the smaller facilities in their geographic region. The levels of maternal care in the U.S. Is not nearly implemented to the degree that could be optimal. This map is an illustration of kind of where it's really only those that are in gray that have defined guidelines that are publicly available that include levels of maternal care. Since this was published, there's been some more progress, and there's a lot of movement in this area, but we've got a long way to go. Texas is one state that wasn't fully integrated and has really kind of jumped in with 2 feet to get this done. They passed legislature in Texas to require that all obstetric hospitals become designated both for neonatal levels and maternal levels by August of 2021 in order to receive Medicaid funding for the work that they're doing. So they're an example of a really robust program that's taken this path very seriously. A couple other things that Dr. Warren already mentioned, that collaborative learning opportunities can support providers in rural areas for sure. statewide quality collaborative work, AIM, which is the Alliance for Innovation in Maternal Health, and implementation of bundles. And then he also already mentioned the maternal health innovations opportunity. There are 10 states doing that are supported now through this. But everything will be available to everyone as soon as it went up on the website, and as these innovations take traction. Just for a minute, I want to talk about telehealth. Telemedicine has been rapidly enabled during the COVID pandemic, and while we all knew it was a promising practice, I think it's now become very visible to maternity providers across the country that we can. And it was enabled by major changes in policy in many states. You can in this diagram with the pregnant person in the center, lactation support, virtual postpartum visits, mental health care is very conducive to telehealth. Online communication with specialty providers, consultation, not so that women don't need to drive long distances. Of course, during COVID, it's just been even close by, so they don't need to have that face-to-face encounter if it's not necessary. Home blood pressure monitoring and other fetal heart rate monitoring, blood sugar monitoring, all of these things have been, we've really turned the corner on making all of that available to our patients and our providers during the pandemic. And it's promising in many states that these policy changes will stay. So it's really going to change the way we offer care locally, but importantly into rural practices. Of course, the broadband access is still a huge issue in some areas, and we have much to learn as to whether this avenue of care delivery will disadvantage certain people, or really will it not having the need to travel, will that be balanced out? We have much to learn, but it's certainly I'm very, very encouraged at what we're going to be able to do with telemedicine. If you want to learn from a group that's been doing this for a good long while and has made huge strides I would look to Arkansas. The ANGELS program, Antenatal and Neonatal Guidelines and Education Learning System. What they put in place, funded by a number of different avenues along the way, is a 24/7 call center for providers and patients experiencing perinatal complications. They have teleconferencing services and providers across the state for training, real-time consultation. I believe now they have about 40 centers where across some sort of hub and scope kind of setup. Where they offer high-risk consultation via telemedicine. And it really has enabled improving the capacity for readiness for rural providers to handle obstetric emergencies. Most recently, there's new work in addressing health disparities and bias and training in that area in their program. And they are really eager to help whoever calls. I've talked with folks from this group a number of times, and it's just been a pleasure to work with them. So, gosh, we need to leave some time for questions and answers, but this summarizes kind of what I see as promising practices to support maternity care workforce. This is Lord Kate Menard's wish list. If Joe Biden or Kamala Harris want a maternal health counselor, here I have it for them in terms of things we need. But this is the things that I've summarized here. And I think I've provided some resources, and now I think we'll welcome some questions from our participants. Thank you for your attention.
Thank you. We will now begin the question and answer session. If you'd like to ask a question, please press *1, unmute your phone, or record your name clearly. One moment, please, while we wait for the first question.
And while we're waiting for questions, I've pulled up the 4 polls. So while you're thinking of your question or typing in your question in the chat, please take a few moments and complete the surveys that we have available now. Thank you.
I'm showing no phone questions at this time.
So in the chat box, we have a question from Candace asking if the presenters, likely Dr. Menard, if you could talk a little bit more about professional doula integration.
Sure. So this will vary in different locations, and I think even within states, there will be varying degree of availability of doulas. Doulas are I think it's important when thinking about which doulas you're going to be working with is to understand their training, because there are some formal programs for doula certification, but there is not requirement for doula certification. So not all doulas are created equal. But doulas do, and some doulas will embed in offices or in healthcare environments, but a lot of it actually happens out of the healthcare environment in homes. They'll connect with individuals in the prenatal period, do a lot of education, prenatal education, listen to their needs, help them, really empower them and give them a voice to ask the questions and get the most out of their care. Similarly, as they come into the hospital, they help with the birth plan. They help give that woman social support during labor and continuous labor support, and empower that woman to kind of express her preferences and needs. And then in the postpartum period, many times these doulas will do home visits. They'll help with lactation support or transition to newborn care, bonding, parenting skills. Ideally, they're culturally matched and from the community, so that there's a tremendous amount of bonding and trust that happens in that environment.
Thank you, Dr. Menard. I think there's a couple of other questions here. From Cheyenne Conway, can you give some examples of payment structures for doulas, hospital-funded, insurance reimbursement, et cetera?
Yeah, I wish I knew more about that. In North Carolina, Medicaid does not cover doulas, and I did provide a resource on my last slide on an article about doulas, where there are a couple of states that are where Medicaid will be covering doula care. There in North Carolina, there really isn't. It's not covered much by insurance either, but some commercial carriers are covering doulas. It's really but it's really the Medicaid population that may need it most. So I think that there's opportunity there to look at policy changes. In North Carolina, one challenge is that they're not licensed providers, right? So it requires some different waivers in order for that to happen.
Thank you, Dr. Menard. So Dr. Warren, I'm going to shift to you in the meantime while we wait to see if there are other questions, and wondering if you could talk about perhaps directing folks to additional funding sources and grant opportunities from HRSA or HHS in general, if you could speak to that and let folks know what might be out there or where they can find that information.
Sure thing. So one general resource to keep handy is the grants.gov website, so grants, grants.gov, G-O-V. And there you can search for funding opportunities from any federal agency, and you can actually drill down and look specifically for the Department of Health and Human Services, and then specifically for HRSA to look for open funding opportunities. You can also look for funding opportunities that are forecasted, so ones that aren't open yet, but that we anticipate having open in the future. I know sometimes folks wish they had more time to prepare and think about what they'd like to apply for, and so that's a trick that I always remind people about, is to look in that forecast section and see what's coming up. The other thing I would mention is to connect and be sure you're connected with public health in your state. So I mentioned our Title V Maternal and Child Health Block Grant earlier. All the states and jurisdictions have that, and those block grants really afford states and jurisdictions a lot of flexibility. They've just gone through the process of doing a comprehensive 5-year needs assessment to see what are the needs and priorities in their state, and then they develop an action plan from that. And the reality is the needs and families of mothers, or the needs and priorities of mothers and children and families in North Carolina are different than they are in New York or Oklahoma or Oregon. And so each state gets to tailor those plans to meet the needs of their MCH population. And if there are maternal health items that are relevant in those plans, you may want to engage your state public health folks to see if there's an opportunity to be a part of that. That may or may not come with funding. Each state is in a different place on that, but they can be great partners. They would also welcome your partners or your partnership in doing this work to move this forward. So I would encourage you to reach out to your state maternal and child health director, get to know them, and look for opportunities for collaboration.
Great, thank you, Dr. Warren. Shifting back to a question from Yvonne, and I'm going to direct this specifically to you, Dr. Menard, and that is, in addition to obstetric and mental health services, are doulas and midwives connecting pregnant women to dental services?
There are lots of dental, I think the answer is yes. I think doulas, when they recognize, or midwives, physician, when they recognize health needs, which includes dental care, will connect to whatever sources are needed. It might be social services, it might be food bank, it might be whatever services are needed. But yes, dental care, and I think in the coverage for that also it varies by state, but many states have robust programs available to women for dental care.
Great, thank you. And I see in one of the polls, there's a lot of comments here on folks wanting to know a little bit more about state-specific resources that can assist with maternal health. And so I don't know if either of the presenters have additional suggestions on where to find that information, or any more detail on that.
Well, Dr. Warren, you might, I think, probably back to the, I'll let you take that one. Yeah.
I was just going to say your state MCH directors can be a place to start. And so if you want to find out who that is in your state, if you will just Google Title V Information System, and the 5 is with Roman numeral V, so Title V Information System, if you will. Google that, and you'll get a directory on our website that has the state maternal and child health director for every state. You can also see their state action plan. So what is it that they're proposing to do in this particular area? So what are they doing around women's and maternal health? What are they doing in perinatal and infant health, for example? And where might there be opportunity? So that would be one place to start. The other thing, in a lot of states, the quality work is connected to organized groups like the State Hospital Association, or maybe the state, if there's a state chapter of ACOG. So being connected with those groups as well can help get you connected to what's going on in that state related to improving maternal health. Those are a few off the top of my head.
And I'll just add a couple. This is Tori Mack talking, just having worked as a neonatologist, but then also at the state level in MCH. I couldn't agree with you more, Dr. Warren, in terms of engaging with your state MCH director. I think that's a great place to start, because they would have the sort of state overview as well as any connections at the county level as well. And, it's not only just sort of where you can collaborate, but then also where are those gaps that potentially the state can't fill that your organization potentially could. I know that's something we valued quite a bit. And the other piece I would also say, from a workforce perspective, to think about your state primary care office as well. We do a lot of work with the PCOs and the PCAs as well, the primary care associations. Just thinking about, especially going back to what we were discussing in terms of the workforce, particularly around where those gaps might be in your particular area as well.
I'll just add that some states actually, their AHECs are active in guiding, guiding and training for the workforce as well. It's just I don't know that that's all states, but
no, you're completely correct about that. The AHEC is a fantastic resource as well.
Great, thank you all for that information. Dr. Menard, you talked a lot about, well, you covered several important topics, including levels of care, and I was wondering if you could tell folks where they could find more information about resources for strengthening perinatal systems of care.
Yeah, if you're not familiar with, the guidelines for perinatal systems of care in your state, then I think, again, your Title V Health Director would be able to guide you. That's also available in that map that I showed you. There's a reference there, and Dr. Valici actually looked at all of the publicly available guidelines. So if your state is one of those, you can see those guidelines. There are, and I'll say that ACOG is very interested in promoting this. ACOG is the American College of Obstetricians and Gynecologists. They are very interested in supporting this work. And contacting ACOG is another avenue to look for support. The CDC has a program available to all the states, and many states have taken advantage of this, where you can do an assessment. The hospitals in your state can do self-assessment of their levels of care. The tool is called a locate tool, and support from the CDC, if your state's interested in doing that, is available as well.
Great, thank you. And I just want to point out to folks that are on this call today that Katie Gall provided some information in the chat and a link from the HRSA-funded Health Workforce Technical Assistance Center, which tracks state workforce data collection. And so the link is in the chat there. And I wanted to check to see if we have any other questions from the audience.
No questions at this time.
Great. One last question for you, Dr. Menard, with respect to telemedicine and telehealth that you had talked about, and sort of the need for evaluation. And it's my understanding right now that there is work underway to better assess telehealth and evaluate its potential, especially during the current pandemic. Can you speak to any other resources that folks can be aware of for evaluating and growing telehealth in their areas?
Sure, I can. There is a lot of evaluation going on related to this. So the HRSA actually funded a project and funded 4 organizations to accelerate the uptake of telehealth during the pandemic, and those organizations will be reporting back through HRSA on their findings too. But you can look to the maternal the MLIC project that Dr. Warren referenced, and the information. There's going to be a report coming out on that MLIC website about the use of telehealth and the needs of telehealth, both nationally. National Provider Survey, as well as Practice Manager Survey, but importantly, the input from community members who have used and experienced telehealth care during the COVID pandemic. Those reports will be coming out on that website probably within the month. Prospective research, because the NIH is funding a lot of research to really kind of evaluate different care modalities. So there's certainly more to come on that as well.
Great, thank you, Dr. Menard. I think that's all in terms of the questions that we're seeing. I don't see any more in the chat, and I don't think there's any on the line.
No questions.
Great. So I want to thank everybody for participating in today's webinar. I also want to thank our presenters, Dr. Warren and Dr. Menard, as well as Dr. Mack for your opening. And I hope you all enjoyed the rest of your day, and certainly reach out to anyone that was on this presentation today with any follow-up questions you might have. Thank you, everybody.
Thank you for your participation in today's conference. Please disconnect at this time.